As you may have discerned, the intent of this program is to alert you to the findings that you can see on imaging that will often lead to misdiagnosis or unnecessary testing. And today I want to talk about imaging of the skull because it's an area where we often see things on the imaging that are not clear to us. Now, these skull lesions are commonly identified on imaging, but just as with the long bones, this benefits from a combination of using CT and MR in many cases to determine the nature of these lesions. Let's see if I can take off these annotations. So the first thing in finding these skull lesions is you have to look at the skull. So looking at this image, even though this is probably done in a bone filter, the skull itself can only be visualized if you window it appropriately. And oftentimes the scout view will provide the diagnosis. So in this example, you can see that there are numerous lucencies within the skull. These represent multiple lytic lesions, and this is a typical appearance for multiple myeloma. So to start, make sure that's part of your search pattern to stop and look at the skull images that are provided and make sure you're looking at them in an appropriate window. As Yogi Berra said, you can observe a lot by just watching. I want to break these findings down into these broad, simple categories. I'm not going to talk about them necessarily in terms of malignancy or benign nature, but just to divide them up in terms of how they appear to you on the scan. So we'll talk about thinning of the skull, holes in the skull, widening, and areas of dense bone. We'll start with thinning. This is an example of a phenomenon called parietal thinning, and this is thought to be congenital in most cases. It is not an abnormal finding. It's just one I want you to recognize when you see it. This is an exaggerated case, and you can see how narrow the bone is here in the parietal lobes. This patient happens to have a fracture, which was probably facilitated by the narrowness of the skull, but this is not an abnormal finding and doesn't require any further testing. On the other hand, this example, and I showed this to you in MR, but of course the same finding would be evident on the CT scan, is that you can see that there's thinning of the bone in this location. The diploic space is narrowed. Here's the normal diploic space in this location. This is due to mass effect from an intraaxial tumor in this case. Now, in order to remodel the skull, the tumor has to be long-standing. And so these are probably pressure effects over years and a difference in the consistency of the brain that leads to this thinning of the skull. So when you see focal thinning of the skull, it's not unreasonable to look carefully at the underlying brain to determine if there is an intrinsic lesion of the brain. In this case, the tumor turned out to be a ganglioglioma, which is again frequently a benign tumor, benign in terms of low grade. Now, in this example, this is a patient who sustained brain trauma, and the treatment of patients with substantial mass effect intracranially in order to avoid herniation of the brain is to remove the skull, called a craniectomy. Here you can see that the skull has been removed in this portion. The patient developed a large extraaxial collection, which is not unusual in these circumstances. Here you can see the overlying skin layer and the subcutaneous fat on the CT scan. The patient went to surgery to have the flap replaced. Now you can see the extraaxial collection was drained. There's an air collection here. So now we have a replacement of the craniectomy flap. This is called a craniotomy now. If you're wondering where the flap is placed during all this time, usually these days it's frozen, although you may see some pictures from the older literature where the flap was often sewn into the abdominal fat, and the idea was to keep it more viable. Now, here's the scan immediately post-placement, and you can see the connecting hardware where the flap is attached to the rest of the skull. Notice the thickness of the craniotomy flap. 3 months later, now look at the flap. This is an example of demineralization, loss of the structure of the craniotomy flap. This is due to devitalization of the flap since it was out of the body for a long period of time. And it's something that you should look for in all the patients who have replacement of their craniotomy flap. I'll show you a couple cases. Here's the scan after replacement of the flap. You can see some of the air at the time of surgery. Now a year later, notice the marked thinning of the skull. In another example, relatively large craniotomy flap. Here it is sometime later. Now we're 2 years later, and the patient is complaining of clicking of the skull. They roll over in bed and they hear a clicking noise. This is one of the complaints that patients will report. And for those of you that drink soda in a can, it's the same idea. Some people call it tin canning, although they're not made of tin anymore. But this idea that the skull is so thin that it moves and will create this clicking noise. The treatment of this, and this is not considered a substantial risk to the patient, but certainly can be problematic, is to replace the patient's native craniotomy flap with a synthetic flap. You notice these holes through the flap. This is now called a cranioplasty. So I showed you some examples of things that will thin the skull. Now let's move on to holes in the skull. In that same concept of replacing parts of the skull, which is called a cranioplasty, here we see this patient had penetrating injury. Here's an area of brain low attenuation as a result of the prior injury from the penetrating injury. Portion of the skull was damaged. And now we see at the site of the injury on this window, you can see pockets of air. When you see pockets of air in the region of a cranioplasty, don't be alarmed at that. Even though the inclination is to suggest the possibility of infection, this is a patient who had a polymethyl methacrylate or PMMA cranioplasty. So the methacrylate that you use when you'll see it in hip replacements, the cement that's used around the acetabular prosthesis, or when you do vertebroplasties, the cement that is used innately is non-radiopaque. That is, the x-rays will go through it quite freely. Remember that this is actually analogous to the plastic used in some windows, so-called plexiglass. So in order to make it visible, there's an additive. It's usually barium sulfate, but if the methacrylate is used without the opacifying agent, it is lucent. And in the formation of the cement, oftentimes small bubbles of air are trapped. And you'll notice in these cases that if you look at them from date to date, even as years go by, the distribution of the air bubbles are the same. So don't be alarmed at not seeing the cranioplasty itself. If this is an older scan, the additives were not used until more recently. And don't be alarmed if you see air bubbles there. particularly if you don't see any air outside of the flap. And of course, look back to older scans and you'll see it, the same air bubbles on all of them. Now, here's a patient after minor trauma, and you see this lucency in the skull. It looks like a hole, sharply defined, scalloped on the inside, loss of the inner table, preservation of the outer table. Now, this is an example of a lesion, and I want you to be aware of these variations of normal, because I believe it is really a disservice to the patient to say in all these cases, can't rule out metastatic disease, consider eosinophilic granuloma, and so on. When you see an erosion like this next to the superior sagittal sinus, this is an arachnoid granulation. So here's the superior sagittal sinus, and you see it's directly contiguous with the sinus. These can be very large. They can go through the outer table. I don't know that I've ever seen one that's extended into the soft tissues, but I want you to be aware of it because it is a fairly common finding if you take the time to look for it. This is what it looks like on the MR scan. You can see there's actually enhancement in this parasagittal location in the bone. Here it is in the bone here, and here it is here. So this erosion in the skull that's immediately adjacent to the superior sagittal sinus in virtually all cases is a normal variant, and this is the arachnoid granulation. Remember, the arachnoid granulations function in the resorption of the CSF. Basically, they're the transition between the CSF and the venous system. So this is how the CSF is resorbed. And these are the same arachnoid granulations that are impaired in function in patients with, for example, communicating hydrocephalus after subarachnoid hemorrhage. Now let's differentiate that from these lesions. These are numerous holes in the skull. These are away from a dural sinus. You can see some of them here, even on the scout view. This is another example of multiple myeloma. Now, again, it's not specific for myeloma. Other metastatic disease will create a similar pattern, but it's the lack of the sclerotic border that you see and the fact that there are numerous that you should consider an intrinsic malignancy or metastatic malignancy when you see this pattern of disease. In this case, the patient presents with a history of seizures, and I want you to notice that this is the normal foramen rotundum. Remember, the fifth cranial nerve comes to the region of Meckel's cave, and eventually the first and second divisions will go through the cavernous, the second division entering by way of foramen rotundum. So this is a normal foramen rotundum. Notice the normal sort of sclerotic margin to it. This is an enlarged foramen rotundum. Some of the possibilities here would include perineural spread of neoplasm, but we should go on and get an MR scan. We have a history of seizures, and you notice it looks like there's brain extending into the foramen rotundum. This is actually a combination of brain and a little CSF coming out through the foramen rotundum. This is an encephalocele. Encephaloceles are often in the paracellar region, medial fossa, nasal region, through the cribriform plate. There's a whole variety of encephaloceles that you can see, combination of encephaloceles and meningoceles. So when you see defects in the skull base, particularly in that location, you want to think about encephaloceles. And this is exactly what I mean when I say that you often need a combination of MR and CT to make the diagnosis in these cases. No, should you have made the diagnosis from the CT? No, there's a variety of things that can look like that. But with the combination of the MR and the CT, you should be able to reach the appropriate diagnosis. So again, this is a encephalocele. Here's a different patient. This patient comes in with headaches. You'll notice a variety of findings here. We have this narrowing of the what's called the mammalopontine space. Ordinarily, the interpeduncular cistern has kind of a box shape. Here it looks like it's pinched in the front. The mammillary body lies below the dorsum sella. We may have some enlargement of the pituitary gland. We have flattening of the pons. We don't really have much in the way of tonsillar excursion, but when we look at the enhanced scan, we see this diffuse enhancement of the meninges. This patient with headaches, these are the typical features of intracranial hypotension. Now, when you see patients with intracranial hypotension, you should be looking for places where there might be a CSF leak. And one of the ways you can have a CSF leak is when you have an encephalocele or meningocele near the petrous bone where it can drain into the mastoid air cells. So when you look at this coronal image, you can see, better seen here, this patient has an encephalocele. This is actually near the tegmen tympani, maybe a little more medial than we usually think, but this is a portion of the brain that's extending down into the petrous bone. So again, another example of a hole in the head. This could be demonstrated on thin section temporal bones. Different case, now we see this lesion has kind of an unusual configuration in the sense that we have this line of bone on either side. It's non-expansile. So can we establish the diagnosis from the CT scan? Personally, I don't think I could make the diagnosis from this, but at that point, if we recommend an MR scan, we see some important findings. It has a long T2 relaxation time. It has no enhancement. It's near a transverse sinus. So the possibilities here is this can be an intradiploic meningocele, which I think this probably is because there's no enhancement in it, or this could be an arachnoid granulation. But in either event, this is a benign lesion and is one of the many holes in the head that you'll see in the region of the occipital bones that is benign. Again, I don't think it's reasonable to start with the diagnosis of metastatic disease. Here's another one. This one's closer to the midline. You see these defects. This is very commonly seen in the occipital bones. These are often called venous lakes, but you'll notice on the MR scan, these actually have CSF attenuation. And here it is on the FLAIR scan. You see it suppresses completely, which again, considerations, I think this could be, because it's again near a sinus, could be thought to be an intradiploic meningocele or an arachnoid granulation. In either event, this is a normal finding. Now, there's one other consideration I will give you is that very rarely in these pockets, you will actually see brain. These are called intradiploic encephaloceles. And these can be the source of seizures. So if you have a patient with unexplained epilepsy that's not of temporal lobe origin, and you see these pits in the skull, again, look carefully on the MR scan to determine if there's brain extending into those pockets. I honestly have never seen a case in my practice of one causing seizures, but I've rarely seen these intradiploic encephaloceles. Here's another hole. Here we see this lesion. You notice it's scalloped on the edges, and there's some bone that's been pushed out in this fashion. This appearance on the CT scan should argue against a metastatic lesion. Metastatic lesions tend not to be sclerotic on the margins because they're, again, rapidly growing usually, and they tend to destroy bone along the front edge. So this lesion we would characterize as probably benign in the sense that we have remodeling of bone, and we have, rather than destruction of the inner table of the skull, we have displacement of the inner table of the skull. Again, MR scan, very helpful. Here we see the lesion. You see this scalloped margin of the bone. It has an intracranial component as well. And when we look on the diffusion weighted scan, it shows high signal intensity on the diffusion study. This is a typical appearance of an intradiploic epidermoid. These are benign tumors, benign in the sense histologically, they can be troublesome when they create mass effect. Here's another one. This patient has headaches. We see this low attenuation region here with this scalloping of the bone, a little bit of preservation of the inner table. We get an MR scan. Here you see the lesion on the FLAIR imaging, it doesn't conform to the signal of CSF on FLAIR. Here it is on the diffusion study, very high signal intensity on diffusion. These are intradiploic epidermoid tumors. So again, this is a very typical appearance. You need the combination, I think, of MR and CT in order to establish the diagnosis here. The frontal and occipital bones are the most frequently involved bones with intradiploic epidermoids. These are not necessarily tumors of childhood, because even though these are thought to be rests of that were implanted early in life, these can present late in life due to the slow accumulation of the material within the epidermoid. Here's the patient with a destructive lesion now at the skull base. Here you see this, the cortex, rather than being displaced, is destroyed. It has this moth-eaten appearance. On a case like this, you always want to go to MR imaging. Here on the MR imaging, you can see this expansile lesion of the skull base that is destroying the clivus, extending into the nasal cavity. This is a clival chordoma. Now, could this be a chondrosarcoma? That's also a possibility. And as we talked about a few weeks ago, that it can be difficult to discriminate clival chordomas from chondrosarcomas. And you might even have suspected a chondrosarcoma due to these little calcifications here centrally. But again, this turned out to be a clival chordoma. Here's a different one with a more typical appearance of a chordoma. This is largely in the prepontine space. You see the brainstem is draped across it. And notice on the T2 weighted scan, the high signal intensity of the lesion, which is a typical appearance of a chordoma. So chordomas, chondrosarcomas, these should be thought of skull base, particularly when you have destructive findings on the CT. I would again recommend having both studies in these cases along with contrast. Now here's another central skull base lesion. Now how is this different than the case I just showed you? Well, if you look carefully, you'll see that there's preservation of some bone here. There's smooth remodeling, a little bit of scalloping. These features should sway you away from chordoma and chondrosarcoma. Here on the coronal scan, again, there's preservation of a bony margin here. So this does not have features of a malignancy. Now, what benign lesion could live in this location? Now we'll look at it on the sagittal view. You can see this resides in the region of the sphenoid, and it has this kind of inhomogeneous quality to it. It does extend through the clivus here. That's okay. This is a sphenoid mucocele. You're used to seeing mucoceles in the frontal sinuses. These frequently will extend down into the orbits, but in this case, this is a mucocele that resides in the sphenoid sinus. Here's another one. You'll notice that it's of high signal intensity on the non-enhanced T1 weighted scan. That's not unusual, as you know, with chronic sinus secretions. Here it is on the T2 weighted scan. Now we know that sinus malignancies are usually dark on the T2 weighted scan, but those are ones that are not intrinsically bright on the T1 scan. And again, this can be misleading on the post-contrast imaging because we know that this lesion is intrinsically bright on the T1 study. This is another example of a marked expansion of the sphenoid sinus. This is a sphenoid mucocele. So again, how can I make the distinction between benign and malignant disease at the skull base? It's important to use this combination of MR and CT. This is an important lesion I want you to recognize just because you'll see it very often. And I think in programs that have skull base services, these tend to get referred in, and you'll see them now and then. This is an area of, again, looks like there's a sclerotic margin. There's some intrinsic structure here. It's in the region of the central skull base. And this is a finding that has been reported. This is called arrested pneumatization of the skull base. This is a good article. I think it's worth reviewing. And one of the findings, which I think can be helpful in these cases, is that they will have a relatively normal marrow signal intensity, which should be a clear indication to you that you're not dealing with a skull-based malignancy. This is a benign process, but it's called arrested pneumonization. I'll tell you, once you recognize this entity, you'll notice it in more and more of your cases. Here's another patient with multiple whole skull. And again, we talked about multiple myeloma. This seems to be a little more regional than the diffuse bilateral cases I showed you. Again, you see these multiple holes in the brain. I think in these cases, you want to consider Paget's disease versus metastatic disease. One of the features that should direct you towards Paget's disease is if there's preservation of the bone marrow in the area of disease. It favors that it's Paget's disease. So metastatic disease will displace the fatty marrow elements, and so will look usually dark, formally dark when you have multiple lesions. But in this case, and you can see these are enhancing here on this fat suppressed T1 weighted scan, this is a case of Paget's disease. So again, those two can be difficult to discriminate in cases, but I would urge you to keep both in mind. And again, not to call everything that has these lucencies in the skull malignancy. So we've talked about thinning, we've talked about holes in the head. Let's talk about some sclerotic skull lesions. Here's a scout view that shows this dense lesion overlying the skull. CT appearance, homogeneously very dense bone. This is what's called an osteoma. Basically, this is an aggregate of bony elements. This is completely benign. It has some cosmetic implications, obviously, because there is a hard lump on the head, but these have no malignant potential, and they should just be recognized for what they are. So this is an osteoma of the skull. Here's another one sort of extending off of the skull. Now, in this case, you see this line separating the skull on this side, which looks a little moth-eaten, but this sharp line with sclerosis on this side. This is, again, another manifestation of Paget's disease. Paget's disease, which is still a little bit mysterious, but I don't think we've gotten past the idea that it may represent some sort of long-term infection, is usually seen in patients over 40 years of age. If you see this in a 30-year-old, you should be thinking of something else. But Paget's disease is something that you should recognize as having a variety of appearances, and you should be thinking of it when you see particularly this kind of unusual pattern of sclerotic and dark bone on CT. Here's a patient was sent in with this central skull-based mass. You can see this expansile lesion coming from the clivus, has this unusual appearance of areas of high signal intensity with T1 shortening. And you can see that there's displacement of the pons here as the tumor has extended up. There's preservation of the pituitary here, so we're pretty sure this is not of pituitary origin. Here it is on the T2 weighted scan, homogeneously dark. This was actually sent in as a chordoma, but of course we know that chordomas generally are of high signal intensity on the T2 weighted scan, and there shouldn't be any rests of high signal intensity on T1, or as I say, areas of T1 shortening in a chordoma. Now, how can we get closer to reaching a diagnosis in a patient like this? We get a CT scan. Again, I showed you this case a couple of weeks back in a skull-based talk, but I just wanted to show it again in this setting. This is, again, another sclerotic skull-based lesion, but this is different than the osteoma. This is an osteochondroma. Osteochondromas should be left alone because in this location, the morbidity from surgery probably exceeds the morbidity of the disease left unchecked. But important to recognize these for what they are. We'll move on now to widening of the skull. Here you can see on this MR scan, sagittal view, that we have marked widening of the skull that looks to be of uniformly low signal intensity. This is what it looks like on the CT scan. Now, again, in cases where you have symmetric abnormalities, it can be difficult to discern them. But you've seen a number of CT scans here today and likely your own experience. And so you should recognize that this bone is sclerotic. Notice how dense the clivus is. Usually, as you'll see, fine trabeculae in here. There's also some thickening here in the sphenoid septation. And this uniformly sclerotic skull should be easy to discern if you have the clinical history. And this is a case of renal osteodystrophy. So patients on dialysis can get this bone sclerosis and widening. And this is, again, a feature of the underlying disease, probably related to the abnormalities of parathyroid hormone. Here's a different page. Now here the skull is thickened. It doesn't look sclerotic, and it preserves a normal bone marrow. Remember this transition from the frontal bone here at the coronal suture. This is in the midline, as you can tell from the midline structures, the mammillary body, thalamus, anterior commissure. This is the transition to the superior the sagittal suture, which will, because of its interlocking bone, will look of low signal intensity on the T1 scan. This is a different entity. So the previous case I showed you, that was renal osteodystrophy. This patient, again, this should be easily to figure out from the history. This is dilantin effect on the skull. Now, these are generally going to be older patients. My understanding is chronic dilantin is used less often in patients with seizures. But this is just one of the findings you should recognize. If you're working in an epilepsy hospital has an epilepsy program, it may be something you'll see time to time. So just be aware. Again, these are, in a sense, they're secondary changes. These are not primary bone problems. Here's another case with focal widening of the skull with these central cysts. Patients 50 years of age. When you see this pattern, again, we're back to Paget's disease. Paget's disease is one that you should be keep in mind whenever you have kind of an unusual appearance of the skull on CT scan because of its many variations of appearance. The things that will help you, as I indicated with MR, frequently there's preservation of the fatty marrow. And of course, the patient's age is something to consider, and because it is not a consideration in young patients. Young meaning, I would say, less than 30. Now here we have focal widening of the skull on the MR scan, and you can see some striated enhancement here, loss of the normal marrow signal, fatty marrow signal. Here's what it looks like on it's actually a plain film. This is an osteosarcoma. Now, primary bone tumors of the skull, at least in my practice over the years, are pretty rare. You'll read reports. I've showed you some, primary bone lesions like osteomas, osteochondroma, and so on. But actual malignant bone tumors, even though they can occur in the skull, like osteosarcoma or giant cell tumors, they're distinctly unusual. And so there are times that you should be considering them, but I generally wouldn't start with that diagnosis because of their low prior probability. But this is an osteosarcoma. Here's another case with a widened skull. I'm going to start with the MR scan because it does look quite alarming on the MR study. Here you can see that there's areas of enhancement. Although you notice on the T1 scan, there's a lot of high signal intensity. Just as with Paget's disease, I think you need to consider when there's preservation of the fatty bone marrow, you're very likely not dealing with a malignancy. And here it is on the T2 weighted scan, quite bright. So kind of an odd combination of findings. Enhancement, T1 shortening, T2 prolongation. This is 3D time-of-flight MRA, and you notice there are actually vigorous flow, areas of high velocity flow within the lesion. So what would have all these features, again, with a symmetry here of the middle meningeal artery, which goes along with those vigorous flow voids within the mass. This is what it looks like on the CT scan. So some people call this a starburst, or sunburst. You know, these striated lines that go through this lesion in this expanded skull. This is a typical appearance of an uncommon disease. This is called a cavernous hemangioma of the skull. It has a very characteristic appearance. It doesn't always look like this. I've seen cavernous hemangiomas that actually have more of a destructive pattern, but this is a very typical appearance. Now, this is benign, again, in the sense of its histology, but this particular case was in a young woman, and because of the cosmetic aspects and the fact that we showed it was growing over time, went to surgery for that reason. It can also be space occupying and displace the brain and perhaps cause symptoms on that basis. But this is a cavernous hemangioma. Here's another one. You notice that on the CT scan, this kind of radiating lines of trabeculae going through this. Here it is on the MR scan, and this is non-contrast T1, and you see there's preservation of some of the areas of T1 shortening. So again, this is a unusual disease with a very characteristic appearance that I want you to keep in mind. This is a cavernous hemangioma. That should be distinguished from this lesion, which is much more common, frequently seen in elderly women in the frontal bone, can show enhancement and be concerning for that reason on the MR scan. But this is what it looks like on the CT scan. Now, in these cases, my practice, I tend to go the opposite way. When I see things on the MR that are enhancing, a single lesion enhancing the skull, particularly in the frontal lobe, I'll recommend a CT scan because I want to make sure I'm dealing with this entity, which is a capillary hemangioma of bone. These are very common, and you see the difference between the capillary hemangioma and the cavernous hemangioma. So the capillary hemangiomas are not expansile, but they have this internal structure that helps you discriminate them from a metastatic lesion, which you might consider based on the MR scan alone. Some people describe these as being to have this kind of appearance resembling a sand dollar. But again, these striated areas within the lesion establish these as capillary hemangiomas. So again, it's a benign lesion. These don't require any follow-up, in my opinion. Now, every once in a while, you see these lesions that you're sort of in between. Here we have this lesion that patient has cancer, and you can see that it has some internal structure, but it's not the fine internal structure that you see typically with a hemangioma. So we're going to get, in this case, we're just going to look back. And when we look 3 years ago, we see it was actually smaller. So this proved to be a metastatic lesion, a slowly enlarging metastatic lesion, I think was from breast cancer. But hemangioma is a consideration, I think, here, but because of the growth, this was biopsied. And in the setting of a patient with cancer, along with the in of the cortex and the lack of the fine internal detail, and obviously this is probably why it was followed for so long, because of its ambiguous nature here. This was a bone metastasis. So beware of these kind of in-between lesions if they're not entirely characteristic. Following along in this theme of the expanded skull, here we can see this patient. This is a 3D volume rendering of the skull. You can see this large bump. The patient presented because of this bump. And you can see this relatively homogeneous pattern with some areas of lucency, but by and large, this is called the ground glass appearance. Ground glass, as you know, is that kind of milky glass you see sometimes they use in illumination. But this pattern of disease with this ground glass appearance, this is entirely characteristic of fibrous dysplasia. Fibrous dysplasia is a very troublesome disease, in my opinion. And this is an example where if you get the MR scan, it actually can be very alarming. So you have to be able to recognize it based on its CT appearance. Here's another example. This is another example of fibrous dysplasia with marked bone expansion. This patient actually was imaged because of the finding on the bone scan. And here you can see this is not metastatic disease to the skull base. This is an example of fibrous dysplasia. This is a case that I came at from the other direction. This patient was referred for an MR scan because she has a history of breast cancer and was having worsening headaches. So on the MR scan, you can see on the T1 weighted study, this expansed portion of the bone here. On the contrast enhanced scan, you see it's bulging into the orbit. It shows this pattern of enhancement, very worrisome in my opinion. And we did broach the question of whether this could be metastatic disease. It was a single lesion. And then we went on and got a CT scan. This is what the CT scan looked like. Again, not destructive in any means. This is this homogeneous, sort of relatively homogeneous by sort of ground glass appearance. The patient on questioning reported that she has known her whole life that there was something unusual about her skull that was diagnosed in childhood. Again, this is an example of fibrous dysplasia, but you can see how alarming it can look on MR imaging. So you have to be able to establish the diagnosis based on the CT scan alone. Another example, just another example of fibrous dysplasia. In this category, I'm just going to talk about lesions that are on both sides of the skull. So very often you'll see lesions like this, where there's abnormal enhancement in the skull, there's a soft tissue mass inside the skull, and a soft tissue mass outside the skull. In fact, anytime you see something that's involving the intracranial compartment and the bone, look carefully for the subcutaneous involvement or subgaleal involvement. When you see a lesion like this, patient you see is 81 years old, that's through and through the skull, the two things to consider are going to be a metastatic lesion, and the other possibility is an intraosseous meningioma. Meningiomas usually don't grow through the calvarium like this, and so when you see it on both sides, we call them intraosseous meningiomas in the sense that they may have arisen actually within the bone itself. But this particular case turned out to be an intraosseous meningioma. But I think metastatic disease in the appropriate setting is a reasonable diagnosis. Now, this is a 3-year-old with this mass that you can see not very well in this image, but it's on both inside and outside. Here you see it a little better here. It looks like there's some striation, but this is a destructive lesion that's going through the skull, has a component inside and outside. The patient has a history of acute myelogenous leukemia, and this is a chloroma. So again, a disease that you really should only be offering as a possibility in patients with either chronic or acute myelogenous leukemia. It's unique to that disease. Now, in this case, I wanted to show you this lesion because it's relatively low attenuation, but it looks like it has some internal structure. So not sort of the typical appearance of a metastatic lesion, but if you're thinking about a hemangioma, you should be concerned about the fact that there is this elevation of the skin, and it looks like there's a subcutaneous component here. And this turns out to be a metastatic lesion. Again, this is an unusual metastatic lesion in the sense that it doesn't have primarily bony destructive disease, but I'll tell you diseases like lymphoma, this is actually turns out to be an extramedullary plasmacytoma, but don't expect bony destructive changes in all cases of metastatic disease. So whenever you're thinking of calling it a hemangioma, be sure that you have very classic features of the hemangioma. Ideally, you might have old images, but if there's anything unusual about it, as I say, in this case, the unusual component, you want to steer away from the diagnosis. So that's all the slides I have for today. I'd be happy to take any questions. I have found in my experience that the skull tends to get neglected in a lot of education because we tend to focus more on the brain itself. But it's troublesome in your practice because if you're reading a lot of CT scans and you're looking, you're going to see a lot of skull lesions. So you have to be able to sort through what are the lesions that need follow, what are the ones that just need an MR scan, and then what are the ones you can just discount offhand. Any questions, or if you prefer to send them through chat, I can. No questions. Well, again, thanks for joining me today. I also wanted to let you know that the recordings of these lectures from now on, I'm going to try to post to YouTube. And if you go to the address on YouTube, Rad Physics Quarantine University, should take you right there. And currently there's 2 lectures. I'll post this as soon as it's available.